about the antihypertensive therapy and the anti-convulsant therapy, let's talk about the timing of delivery. So we understand the fact that delivery is the only definitive management of hypertensive disorders. And here we see that if the preeclampsia is without severe features, the timing for delivery is 37 weeks. If it is severe preeclampsia, if the woman is less than 34 weeks of gestation with stable maternal and fetal condition, it is recommended that continued pregnancy be undertaken only at facilities with adequate maternal and neonatal intensive care resources. And if she is equal to more than 34 weeks gestation or even under 34 weeks but with unstable maternal or fetal conditions, delivery has to be initiated soon after maternal stabilization is done. So the cutoff for severe preeclampsia is 34 weeks, whereas the cutoff for non-severe preeclampsia is 37 weeks, right? And any time when there is an unstable maternal fetal condition, when you are doing an expectant management, there are certain criteria known as the Sebias criteria, which tell you that you have to stop the expectant management and go ahead, proceed with the delivery. And whatever the delivery timing in chronic hypertension, you deliver her of about 38 weeks. And gestation hypertension, you can wait up to 40 weeks, but don't allow her to become post-dated. Okay. So this is the timing of delivery in different case scenarios. So what are the guidelines for the expectant management of severe preeclampsia less than 34 weeks? I just told you that if the woman is less than 34 weeks and she's stable, we can go in for an expectant management. So what all you need to do in that expectant management, you hospitalize the woman. I'm talking of severe preeclampsia here. That means, again, the BP is equal to more than 160 or equal to more than 110, or there is evidence of end organ dysfunction, or there is fetal growth restriction. All these Chesley's criteria we had heard and learned in the first half of the lecture. So hospitalize the woman, do a daily weight monitoring, daily input and output charting. Antihypertensive therapy has to be instituted depending upon the BP readings. Betamethasone 2 12 mg doses 24 hours apart for ensuring fetal lung maturity. A lab assessment with AST, ALT, LDH, platelet count, serum creatinine, bilirubin and 24-hour urinary protein. By now I am quite confident of the fact that you know what is the significance of each and every test. So AST, ALT for the liver dysfunction, LDH to assess hemolysis and qualify the woman for HELLP syndrome, platelet count for knowing the status of the coagulation parameters, creatinine for the renal status, bilirubin again for hemolysis, and 24-hour urinary protein to know the renal function. Okay. So all this laboratory assessment has to be done. If she's a case of severe preeclampsia, you have to do it every 48 hours, right? So you do it 3 times a week. And if she's a case of non-severe preeclampsia, you do it twice a week or bi-weekly. Okay. Yeah. So twice a week in non-severe and thrice a week in severe preeclampsia. Daily fetal movement count. I told you that along with maternal well-being, you have to ensure the fetal well-being as well. So DFMC weekly to as frequently as daily NST depending upon what is the condition of the uteroplacental flow. Umbilical and middle cerebral Doppler twice every week. Amniotic fluid volume assessment twice every week. Ultrasound for fetal growth again every 2 weeks. These are the things you need to do when you are going in with the expectant management. So maternal monitoring and fetal monitoring in terms of the sonographic monitoring, the daily fetal movement count and the biophysical monitoring of the fetus. Now you are going in with the expectant management. That what happens when this expectant management has to be interrupted and one has to move to delivery? I told you this is guided by the Sebias criteria. So what is the Sebias criteria? Again, we have maternal criteria and we have fetal criteria. So you're going on with the expectant management, but if the woman complains of either persistent severe headache or visual changes, she throws a seizure, that means she becomes eclamptic. There is evidence of shortness of breath or chest tightness with auscultatory rails or rales, and or an SpO2 of less than 94% at room air, evidence of pulmonary edema, BP is uncontrolled despite treatment, there is oliguria, an output of less than 400 to 500 ml over 24 hours, or the serum creatinine, it should be a more than sign, a serum creatinine more than 1.5, persistent thrombocytopenia with a platelet count less than 1 lakh, or there is a suspected abruption progressive labor and a ruptured membranes or an intrauterine death, you have to proceed for delivery. So you understood the maternal criteria. Basically, if there is any evidence of organ dysfunction, like if the brain is being affected, there's severe headache, the eyes are being affected, visual changes, there are seizures, there is pulmonary edema, and the BP is uncontrolled, the kidneys are being affected, which is evidenced by rise in serum creatinine and in oliguria, or there is hemodynamic worsening, persistent platelet count, which is less than 1 lakh, or suspected abruption with progressive labor, ruptured membranes, or an intrauterine death, you proceed to delivery. After reading the maternal bias criteria, let's check what is the fetal criteria. So if there is an evidence of severe growth restriction with an estimated fetal weight less than 5th centile for that gestational age, you see a reversed end diastolic flow in umbilical artery Doppler, or even an absent end diastolic flow, right? Persistent severe oligohydramnios, an AFI of less than 5 centimeter, a biophysical profile of less than 4, and done 6 hours apart. So you get a BPP less than 4 on 2 occasions, 6 hours apart, or fetal death. That would call in for interrupting the expectant management and proceeding towards delivery. So severe FGR, reversed end diastolic flow, persistent oligohydramnios, a BPP less than 4, and intrauterine death. These are the fetal criteria to move to delivery. So we read about the expectant management, right? And we read about the criteria to move to delivery. Now, once we have decided the timing of the delivery, next comes a decision on the mode of delivery in women with hypertensive disorders of pregnancy. So it's a dictum that vaginal delivery is preferred for women with any type of HDP. Because in cesarean section with onset of anesthesia, there will be mode of hemodynamic changes. And we know that a woman who has a preeclampsia set in is not able to withstand lots of hemodynamic changes. So ideally, a vaginal delivery is preferred, and a C-section is required only and only for obstetric indications. Now, the choice of anesthesia, if needs to be given, would be regional, unless she has a platelet count of less than 75 to 80,000, where epidural might run a risk of epidural hematoma, and then GA can be given. So rule out contraindications such as thrombocytopenia beforehand. So go for vaginal delivery, do a C-section only if there is an obstetric indication. Anesthesia choice would be regional. If the platelet count is less than 75 to 80,000, go for general anesthesia. Now the woman is in labor and you need to do an intrapartum care. So during labor, you measure the blood pressure hourly in women with hypertension and every 15 to 30 minutes until the blood pressure is less than 160-110 mmHg in women with severe hypertension. So if she is a case of non-severe preeclampsia, do an hourly BP monitoring. If she is a case of severe preeclampsia, you need to measure the BP every 15 to 30 minutes. Do not preload women who have severe preeclampsia with intravenous fluids, right? Very, very important, because I told you they have leaky capillaries and endothelial dysfunction. So whatever fluid you're giving, it's not going to stay in the intravascular compartment. Rather, it will go extravascularly. So it will result in all sorts of complications, most dreaded of which is pulmonary edema. So do not preload the women. If you have to give fluid, give RL or NS at the rate of 75 to 80 ml per hour. And this has to be conveyed to the anesthetist as well, because ideally what happens, they preload the women with up to 1 liter of crystalloid before giving an epidural or a combined spinal epidural. But this has to be avoided in women with established preeclampsia. Now, do not routinely limit the duration of the second stage of labor in women with controlled hypertension. It is not needed to cut short the labor. You do it only in women with severe preeclampsia who have a worsening cardiac and pulmonary status. This is straight away from NICE guidelines 2019. You can have a look up at the NICE guidelines as well. Consider operative or assisted birth in the second stage of labor for women with severe hypertension or whose hypertension has not responded to initial treatment. Okay, so do an assisted vaginal birth only in women with severe hypertension with worsening cardiac and pulmonary status who are uh, not able to sustain or entail the bearing down in the second stage of labor. Now the woman has delivered, right? So what is the post-delivery management? So you've done a beautiful antenatal care. You have taken her through her pregnancy well. You have delivered her, you've given her a good baby. Now, the responsibility does not end there. Okay, post delivery you have to do a close vigilance for eclampsia. I told you that even postpartum eclampsia may set in within 24 hours of delivery or even up to 10 days postpartum. So look for eclampsia, look for signs of postpartum hemorrhage, again health, pulmonary edema, cardiovascular or cerebrovascular events, and thromboembolic complications, right? So these are all which can happen in a woman with PIH and HTP and have to be looked for with close vigilance and strict monitoring. Now, during the hospital stay, the blood pressure should be closely monitored for the first 48 hours post delivery. So you have to take a BP recording of up to 4 to 6 times a day. Postpartum use of NSAIDs should be avoided because we know there is already some amount of renal compromise, right? So it's better to avoid NSAIDs, and if they want pain relief, you can simply give paracetamol. What about the antihypertensive therapy? So in pregnancy, we have the cutoff of 135 by 85 as decided by the NICE guidelines. Here we can be a little liberal with them. Antihypertensive therapy is recommended for persistent BP of systolic more than 150 or diastolic more than 110 in the postpartum period. And a persistent BP of more than 160 systolic or 110 diastolic should be treated within 1 hour with intravenous antihypertensive therapy, and then magnesium sulfate should be considered for seizure prophylaxis. So where the target is 135-85 in antenatal women, we can defer therapy until systolic is more than 150 and diastolic is more than 100 in women who have already delivered. But if there is an evidence of severe preeclampsia like BP more than 160, 110, institute intravascular antihypertensive therapy and go for magnesium sulfate prophylaxis in order to prevent seizures. So what all complications can happen in this journey? Eclampsia amongst the maternal complications, HELLP syndrome, yes, the hemolysis, elevated liver enzymes and low platelet syndrome, abruption placentae, because preeclampsia and hypertensive disorders are a known risk factor for abruption. There can be a retroplacental hemorrhage, pulmonary edema, which results in lots of maternal mortality associated with PIH, stroke, that means a cerebrovascular accident, then multiple organ dysfunction entailing renal failure, hepatic failure, hepatorenal failure, even myocardial infarction or disseminated intravascular coagulation. So these are the maternal complications of HTP. Now, as far as the fetal complications are concerned, because of the uteroplacental insufficiency, the baby can have fetal growth restriction. There can be an iatrogenic prematurity, or even spontaneous preterm labor is high in these women. Oligohydramnios, fetal hypoxia, high incidence of category 2 or category 3 tracings in cardiotocogram, increased absent or reverse Doppler flow studies. I'm sorry, it's not increased, it is decreased flow, absent flow or reverse flow in the Gynaecology Doppler, a low biophysical profile score less than 6 or less than 4, and even an intrauterine death. So there are a host of maternal and fetal complications in HTPs, and ideal would be to screen these women early in order to prevent these catastrophic complications.